Welcome to Advanced Hydrus Weak Hand Rescue. This is a case where the intended superinasal insert using my right hand was just not possible, and this does happen more than once a month, I would say, due to either visibility, because the patient may not be able to look in the proper direction, or perhaps the angle has a problem, as in this case. I got a little peek there, and then I'm going to take a better look. So I'm sorry we went off the screen a little bit here, but the first time I looked at the angle, I noticed that the canal was nicely filled, heading south, which is infranasal there to the right. But the left direction, which would be superinasal in this right eye, does not have any backfill, and this is after cataract surgery, so the canal should be completely filled with heme at this point. So I took one last good look, and here's a freeze frame showing what really caught my attention. There it is. So you can see the heme kind of dives posterior right in the center, and I'm wondering if that's a septa or if there's just some maldevelopment of the canal in that area. So I'm not even going to attempt that. I'm going to ask for my right-handed lens. I'm going to take the paracentesis blade and make an opposite para using overhand grip, 4 o'clock hour target. You can see I'm aiming just beyond the intentional sight. So if I'm going to insert at 3 o'clock, my paracentesis is aimed at 4 o'clock, just 1 clock hour beyond. And that really gives me the ability to orelock the eye and grab hold of the cornea and keep everything more steady. I find this is so much superior to using a paracentesis directed exactly at the insertion site, because then there is no stability with the wound. So here I am trying to obtain my en face view. Again, I'm going to switch to my right-handed lens. There is also a Volk universal, which is 360, and Glaukos makes a wide-angle universal as well. But these are the old original Glaukos lenses where I have left and right-handed ones. So here I am. I've readjusted my Hydrus. Now it's going to be 30 degrees to the right instead of 30 degrees to the left. And we're going to obtain our en face view. I'm going to have to ask the patient to look away and readjust everything. And whatever I need to do, I will do. If I have to readjust the scope, their head, it just doesn't matter. You have to have this really nice flat en face view. There it is right there. Perfect. So now I know I'm ready to go. Insert the Hydrus. I prefer a tip down insertion, and then I focus right on the tip, very anterior, and then as I advance to the canal, I advance my focus with the tip. So here I am, a little false alarm there. Then I'm going to readjust. Apologize for the dark video. I think the angle of the lens was not able to pick up the exposure very well. But we'll see the Hydrus go in very nicely, and then in a second I'll have a better view for you there. There, the Hydrus is well positioned in the canal that had the heme. And then we're just going to finish up as normal with the standard IA to remove the viscoelastic. So I find the need for a weak hand insertion is not rare. I do it at least once or twice a month because just various things happen that do not permit the intentional primary implant. And it's a really great skill to have, especially if you're going to be doing temporal Hydrus implants sitting nasal and working over the nose. Those cases are the most challenging and very often do require weak hand insertion. So that's the the basic technique, and once again we reposition the head back to neutral. After every Hydrus, I always reposition back to neutral. There it is in real nice shape. This was a small pupil case with nice floppy iris there. And there we have it. Thank you very much for your attention to this advanced Hydrus weak hand rescue.